I'm Chelsea Menchen, the National Projects Manager at Palliative Care Australia, and today I'm speaking with Dr. Paresh Dawda, and we'll be discussing the National Palliative Care Standards for all health professionals and aged care services. These standards have been developed by Palliative Care Australia, and they're intended to support those working but in palliative care, but not in specialist palliative care. So it's for all those other settings where palliative care is delivered. And they're designed to support people working in those clinical settings and care settings in order to provide quality palliative care so that everyone can access it. Good morning, Paresh.
Good morning.
We just wanted to give you an opportunity first to have a little bit of discussion about the work that you've been doing. I understand that you're a general practitioner working across the life course, so people from cradle to grave, with a special interest in multidisciplinary care and chronic and complex conditions, and working specifically in aged care as well. Did you want to give us a bit of an overview about your background?
Yeah, sure. Thanks, Chelsea. And thank you for having me. I've been a GP since late 90s, and I guess my interest in palliative care really started and got ignited when I was a GP registrar. And I had, there's a couple of cases where just having compassionate and honest conversations with families just made all the difference. And I still remember both those families, almost 30 years later, and what they said to me at the time around that honest conversation allowed them to come around their loved one at the end of life and actually make what's a sad experience an experience that's a good death, if you can call that. And my interest in palliative care has really grown both from a clinical perspective and a service delivery perspective ever since then, really, such that the main focus of my work now is very much people with complex and chronic conditions, and a palliative care approach, that's a holistic, psychosocial and biomedical approach, all kind of incorporated into one. It's kind of a philosophy I try and work with all the time.
So talking about that intersection between primary care and palliative care, what do you see as being the really important factors there?
When we're talking about different sectors, when we're talking about primary care, palliative care, aged care, disability care, sometimes this picture of a Venn diagram appears in people's minds with circles and little bits overlap. I actually think where we sit in primary care as first contact care, continuous care, comprehensive care, actually all the circles in the Venn diagram all overlap. It's not that there's only little bits of overlap. It's almost like they completely overlap. So I kind of feel very strongly that the sort of philosophy, the approach behind palliative care, particularly as we get a growing population, as we get multi-morbidity, people living longer with chronic conditions, and people's desire for their end of life to be often in their homes. Many have that preference. I think when we think about all of that together for primary care, and particularly for general practice, I think it's got to be a way. It's got to be the philosophy of how we practice and deliver care.
Especially when we are looking cradle to grave, it provides that approach for the end of life to really have meaning and quality. And I think it has that for the providers as well. What do you think are some of the barriers that general practitioners in particular may find with comfort levels in talking or supporting palliative care?
Look, I think of the barriers along a sort of number of streams, if you like. I think there are regulatory barriers and barriers around lack of aligned frameworks. I think there are workforce-related barriers. I think there are financial-related barriers, without a doubt. And then there's education, training, and capability and capacity type of barriers. When I think of each one of those streams, regulatory and aligned frameworks, we often have all these different sectors, whether you've got the specialist sector, whether you're looking at aged care or disability, they've all got their own governance arrangements, their own frameworks, which may be inclusive of palliative care. The problem is that approach in their framework may be different to the approach in, say, primary care and general practice framework. And so whilst everyone's got an intent around doing the right thing, the regulation kind of becomes a bit of a hindrance and barrier. So I think that's one particular issue. And I think that's where the standards are great, because the standards are voluntary, but they're across all of those non-specialist palliative care services. So we can all start to work from the same, start to look at working from the same page, have a sort of common purpose around it, which I think is really important. I think workforce, to do palliative care well, I think requires a team-based approach. It's not about the lone type of thing. It really does involve a broad team-based approach, and certainly I think GP is a very important part of that team member, but other members of the general practice team, like the practice nurse, who's often involved in care planning and health assessments, I think is an important member. Increasingly, practices are having other members of the team, like we have a practice pharmacist in our practice. And so that whole idea around understanding what's important to the person and de-prescribing when it's no longer appropriate to have those prescriptions ongoing becomes important. We're also fortunate that we've got a social worker who's a tremendous asset in the practice to support families and carers around all the social aspects. So that's just like the core team. But then, when we think more broader, that web of care for a person who may have palliative care needs may well include other members of the team. So you've got the specialist services. It could be a physician, it could be a surgeon, it could be an oncologist. If they're in the aged care sector, then it could be the carers in aged care, the nurses in aged care. If they're at home and receiving home care packages, then again, it's those team members from that up part of that. And increasingly, we're seeing hospital systems using hospitalization avoidance schemes. So you have intermediate care services such as hospital in the home, or sort of rapid response service, which kind of outreaches to people in their home or in the nursing home. When you start to look at who makes up that team, that's a core team, but there's this broad range of providers, services that come into play. And of course, the biggest challenge is, how do you keep everyone on the same page? How do you keep all that coordinated? How do you keep the communication happening with the patient at the center? Because that's the critical thing here, I think.
And in developing the standards, it was really important for allied health professionals outside. The people often think about our OTs and our social workers, which is so critical. But there's also the services like art therapy and music therapy that people can bring into that team as well. So I understand, because you've been working in the palliative care approach for quite a while now, that you've developed and established a team that's able to support the holistic nature of palliative care around you. How do you think these standards could be used by sole practitioners or practitioners that don't have a full team within their own practice to build their networks and to support them to be able to refer?
I think it comes back to something I was saying earlier around, when we're looking at different craft groups, people are often working to whatever their professional organization might have in place, in terms of guidelines, frameworks, alignment. I think what the standards do is they cut across all those crafts. So it doesn't matter whether I'm a GP, a physio, OT, a pharmacist, a social worker, an RN in aged care, or a oncologist. The standards are relevant to me, irrespective of my craft. And the importance of that, I think, is each member of the team in that web of care for the patient, those standards are relevant to them, each member of that team. And therefore, it starts to create a conversation and a dialogue around a shared purpose, around what we're trying to achieve, but B, the standards and support how we achieve that. And so I think that's the critical value. I think that's where they really add value. Is around providing a focus around. I think what we all have an intent in doing, but we come from sort of different perspectives. It unifies those different perspectives.
And I think they support people to know what systems can be put in place as well. A bit aspirational as well. Just speaking to Standard 1 now, if we just do a little bit of a deep dive into one of the standards and talking about the importance of comprehensive assessment of needs for quality patient-centred care. Did you want to just discuss that issue?
Yeah, look, I think it's worth just taking a step back and thinking about, A, what do we mean by comprehensive, and B, what do we mean by person-centred care? And, I think in this sort of context with a palliative care approach, when we think about comprehensive, it very much is that holistic nature. It's very much not only the person's physical condition and their biomedical aspects, it's the psychological, it's the social, it's the cultural, it's the spiritual, it's the whole of that person and what makes up that person now, and their past experiences as well. And then I think when we're thinking about person-centered and what do we mean by that, I think for me that brings together 3 or 4 things. First is about individualizing. So it's not a cookie cutter approach. It's very much around understanding what's important to that person, what matters to them, and then trying to achieve that. It's about coordination and connecting, making sure that all those services we talked about earlier around the web of care actually speak to one another and are coordinated. And in doing so, what we want to try and do is avoid repetition, and we want to avoid duplication, because otherwise people end up telling the story umpteen times to multiple individuals, and we know the feedback we get from consumers is that the services need to be seen as one service from a patient's perspective. I think it's about person-centered care, it's about enabling. So where possible, supporting that person to achieve the things that matter to them. And then I think the 4th element of that person-centered care is the relational aspect. It's compassion, respect, dignity, and all those aspects. So, if that's what we're thinking about when we're thinking about comprehensive person-centered care, I think to do that well need to be inclusive of all of those components. I think to do that well requires bringing all the team members onto the same page, and that requires processes and tools we can use across the system. So, tools like having a shared care plan, for example, having a systematic, structured approach to identifying people with palliative care needs, so we know who would benefit from palliative care approach. Using the sort of tools around that framework, around the palliative care framework, to have those open, honest dialogues, compassionate dialogues with patients, and supporting them in that shared decision-making process, the enabling part of person-centered care I was talking about. So to me, Standard 1, the importance of that comprehensive assessment and need for quality person-centered care is really about all of that. It's about a holistic approach. It's about having processes in place. It's about using tools, of which there are many. We just need to, as a team, as that broad team, adopt them and all use the same ones, and keeping the patient at the center. So always having that sort of shared decision-making approach with them, where they're part of the process rather than, things done to them. Not having things done to them, but with them, that sort of philosophy.
So you're really big in the multidisciplinary care, and you're a big advocate for multidisciplinary care. Can you speak to Standard 5 then, which is about the importance of integrated care in delivering quality patient-centred care?
Look, I think, again, my first key message would be, let's just have a common definition around what we mean by integrated care. Because, in the literature, there's 176 definitions of integrated care. But what's really important, again, and common to all of them, is the organizing principle of integrated care being around the patient. So, bring it back to standard one. So standard 5 is around keeping the focus on standard 1. And then when we're thinking about it, that integrated care approach, I think, again, understanding what's important. So people want to minimize transfers where possible. They want to have care in place where possible. We said earlier about not repeating the story multiple times. All those things are important. So when we think about integrating, continuity of care is a big part of that, I think. And when we think about continuity of care, there's 3 particular aspects. There's the relational aspects, to try and keep that relational continuity of care where possible. There's the informational continuity of care, so that's sharing of information between the different care providers consistently and systematically. And then there's that sort of management continuity, so the proactive coordination of care and services around that, and the example I kind of always highlight here is when somebody passes away, for example, making sure the rest of the care team are notified about the death, because it's so unpleasant, I think, from a carer perspective, to receive an appointment for a specialist service after someone's passed away because someone's failed in the notification of that. So that's just a very tangible example of how coordination, that management continuity and information transfer is so important, because without that, an experience can become very negative very quickly.
Absolutely.
I mentioned a couple of things earlier, and I think they become really important when we think about integrated care. So that shared care plan, having one plan for that patient that the whole care team work with and work towards. And again, using the enablers in the system, like case conferencing, for example, to make sure everyone's on the same page, working together, clarifying roles and responsibilities, and building trust, because trust is such an important part of integrated care. There's this sort of saying which comes from the King's Fund in the UK, where they say integrated care happens at the speed of trust, and things like case conferencing, communication, etc., between the care team allows that trust to develop, and that can only lead to better care.
In the palliative care approach, we do talk about engaging the carers throughout the process, and that we're also providing palliative care approach for the carers and those that are likely to be, bereaved when the person does eventually die. With the standards and just in your practice broadly, talking about that example of where, someone may receive a notification for a reminder of an appointment and things like that, they all impact the bereavement process afterwards. So have you got any insights on just how to support carers and how to carry them through the journey with you to inevitably improve bereavement for them?
Look, again, I think it's a really important part of palliative care. So in the care plans we do for the patient, we have a little section in there around post-death care, and that includes bereavement care. We're fortunate in that we've got a social worker in the practice. Our social worker often takes up the responsibility of contacting people after someone's passed away to check in with them to see how they're traveling, signpost them to a number of services. So I think, one of there's so many services and community assets out there. It's about how we leverage those. And so this kind of concept of social prescribing and understanding what's out there and then leveraging and signposting people to those is really important as well. So, again, I think that bereavement care starts with awareness, identifying the need, information provision, enabling people, and where that's not enough, and then clearly a more sort of one-to-one approach becomes apparent, and engaging that person to tap into their primary care provider, tap into their GP. So because we do a lot of aged care, some family members may be our patients, but often they're not. But what we proactively try and do is encourage them to go and see their GP and speak to their GP if they're not a patient of our practice. Just because I think the standards are, they're voluntary, but I think they're so important. And I would really encourage services to look at them and, pick up a standard and just think about what's the relevance of that standard to us. And it starts to help think about what we can do better. And I'm particularly passionate about, the quality improvement standard, which we haven't touched upon this morning. It's about pursuing perfection, not being perfect from the word go. So, I think that quality improvement approach is so important. The important thing I think here is when we're thinking about quality improvement, and when most organizations do quality improvement, they tend to do it in their silos. We might improve the care planning that we do in our general practice, but that's separate from what the nursing home may be doing around their quality improvement with respect to palliative care. And so one of the things I think the standards do is, again, open that up. So, we can start to say, what can we do together collectively to improve the quality of care for patients with palliative care? So, as an example, again, one of the things we've started to do with the PEACE team, which is a sort of specialist outreach palliative care service, the aged care facilities, and ourselves, is actually when a person's passed away, do a audit of the quality of that death. And we're just going through the learnings from that, because that then will become a stimulus for what can we do better collectively rather than individually. So, I'd like to just emphasize that standard, because I think it's such an important one around building that normative integration, how we start to culturally work better together in a sort of normative way.
That's wonderful. Thank you so much, Paresh. The National Palliative Care Standards for all health professionals and aged care services is available on the Palliative Care website at www.palliativecare.org.au. Thank you for joining us today. And thank you, Paresh.
Thank you.